Well, welcome to our first Women's Health and Wellness Lunch and Learn series. My name is Joanne Kaiser-Smith. I'm a professor of medicine at Rowan University School of Osteopathic Medicine. Today, you will be starting the inaugural event of our Lunch and Learn series. Dr. Brecher, who you will meet shortly, and I have been educating our patients about health issues for over 30 years. We thought it was a great time to share our knowledge and the expertise of many of the women professionals within the Rowan family. While we may be physically apart during this pandemic, we are all the same in the fact that COVID-19 pandemic has affected us in many ways, our health, our relationships, and our sense of well-being. We hope to provide you with some guidance to help you focus on yourself and your needs. What better time to start this than during March, which is Women's History Month? Our event today consists of two presentations followed by a question and answer session. Please note that our speakers are unable to address any specific health issues, but will answer general questions. Our presenters are practicing physicians within Rowan Medicine who are available for patient care through Rowan Medicine should you choose to follow up with them. Thank you for joining us today. Let's turn our attention to our first speaker, Dr. Morgan Vermoulin.
Thank you so much, Dr. Kaiser-Smith and Dr. Brecher. It's a pleasure to be here. I'm going to go ahead and share my screen and we'll get started. All right, does everybody see that okay? Wonderful. So as Dr. Kaiser-Smith said, I'm Dr. Meagan Vermeulen. I've got a lot of titles and they sound fancy, but I'm pretty down to earth. So I just want to get that out of the way. So I am an assistant professor in the Department of Family Medicine here at Rowan SOM. I'm also the medical director for our new Rowan Family Medicine office in Sewell at our brand new campus in Sewell, New Jersey. And I'm the founding program director for the new Inspira Family Medicine residency program at Mullica Hill. We're going to be partnering with Inspira for educational deliverables at our new campus and beyond. And we're super excited to be here this afternoon. So as Dr. Kaiser-Smith mentioned, we're all in this together. It's actually been a year today since lockdown kind of happened. Last year, yesterday, the WHO declared COVID-19 a pandemic. And we all know that this is a pandemic that has disproportionately affected women, working women in particular. So in thinking about a topic to bring to you all this afternoon, I thought it was important that we kind of get back to basics. We talk about resiliency, grit, and self-care, not only during the COVID-19 pandemic, but this is something we need to keep an eye on in the future. It's not just, okay, the pandemic's over and we can go back to what we were doing. This is a really important topic for your overall health and wellness. So this is getting to the nitty-gritty, resilience, grit, and self-care during social isolation and beyond. So our learning objectives, I think it's important we have a little bit of a starting place so we know where we're going. We're going to describe the difference between social isolation and loneliness and their effect on your mental health and really on your physical health too. We're going to define and differentiate grit and resilience because they are actually two different things. And we're going to develop strategies for self-care during the COVID-19 pandemic and beyond. So this is the inspiration for my topic this afternoon, in addition to the fact that it's the anniversary of lockdown. About 6 weeks ago, I did a community talk for Sussex County Community College. It was an invited discussion on their college novel, on The Martian. And I thought it was very appropriate that The Martian was the book that we were talking about, because anybody who knows the story either have read it or seen the movie. The Martian is about an astronaut that gets stuck in isolation on Mars. And that is the definition of physical distancing and social distancing. He's there, he's by himself, and he's got to figure out how to survive. And part of the discussion that we led was based on, well, what did he actually use to get by while he was stuck on Mars? And how can we actually use these in our everyday life? And it really got me thinking about the importance of differentiating isolation versus loneliness, because they actually are two different things. And what are the tools that we can use? Can we learn a little bit from fiction and really incorporate them into resiliency strategies for real life and for mental health and physical health? So social isolation is actually a lack of social connections. A lot of people use the term physical distancing instead of social distancing when the pandemic first hit, but it actually technically describes physical distancing and a lack of social connections. This is super important for us to think about, because when you are socially isolated, you have increased risks of not only mental health disorders, but of physical health. We absolutely know that there's data that shows that lack of social connection has increased risks of cardiovascular diseases, and that's heart attack, stroke, peripheral vascular disease, dementia, and all the different forms of memory problems that go with that, and even death. People who are socially isolated are far more likely to die in an early age than those who are physically connected. There's been a new study that was published by the National Academy of Science, Engineering, and Medicine that points out that a third of adults age 45 and older, and nearly 1/4 of adults age 65 and older are considered to be socially isolated. And that's something we really want to think about. It's not just people who are over 65. When the pandemic first hit, we really thought about, oh gosh, what are we doing with our grandparents who are in their 70s or 80s, and they're really isolated from us. We think about over 45, a third of adults in this country are considered socially isolated. That's pretty young. So this is not just a disease that disproportionately affects older people. Loneliness is not the same as being socially isolated. Loneliness is that feeling of being alone and feeling like they're emotionally isolated. It's regardless of the amount of social contact. You can be socially isolated and not feel lonely. You can be socially connected and feel really lonely. And that's a very important distinction for us to make. Feeling lonely, the perception of being alone, puts you at an increased risk of worsening heart failure, depression, anxiety, suicide. All of these very real problems, both physical and emotional, get worse when you are feeling lonely. It can affect some people, again, when they seem like they're a social butterfly, they seem like they're super connected, they may still feel very lonely in the room. They may still feel very lonely in their life. So you really want to think about, just because you're having contact with these people and they're in your social network doesn't actually mean that they're feeling connected emotionally. I think it's a very easy analogy to make when you see people who have 500 friends on Facebook or 1,000 followers on Instagram. That doesn't mean that they're not feeling actually very lonely and are therefore at risk for all of these problems outlined here and even more. So, pandemic life. There's a lot of factors that have been at play in the last year, and a lot of factors that are not just going to poof, go away when we move on to people being vaccinated or herd immunity. In the last year, there's been physical isolation for everyone, not just those who are already socially isolated. There's so many patients in our panel who've had economic stressors, increased risk of healthcare disparities. We have seen, again, this pandemic has disproportionately affected people who are socioeconomically depressed and have lack of access to healthcare. And there's been a dual pandemic. We've been dealing with racial injustice for a very long time in this country, and it really came to head last May with the murder of George Floyd. So all of these factors compounded the very real COVID-19 pandemic that we're all experiencing. I think we forget that this is not actually a new phenomenon. It's just not one that we as Americans have really dealt with a lot personally. We forget that SARS was a pandemic that affected different parts of Asia. The H1N1 virus, I practiced when H1N1 became a thing. It was really hard. We had very sick people in the hospital. It was absolutely at a pandemic level. It was really stressful. It was just handled in a different way. And of course, MERS. All of these pandemics have been very real. They've affected sections of the world, but the whole global connection that we're all experiencing is different for COVID-19 because of things like interconnected travel, international travel. We're so used to being able to just come and go in a moment's notice that everything screeched to a halt. And all of these compounded each other: the physical isolation, the economic stress, the increased healthcare disparities, and that dual pandemic. So, grit and resilience. why are we talking about grit and resilience? Why are we, and I promised Dr. Kaiser-Smith there would be no actual pictures of Gritty on here. For any of you who love the Flyers mascot, I personally find him slightly disturbing. But yeah, I'm a big Philly fanatic fan, I gotta say it. But yes, we're gonna talk about grit and resilience and not just Gritty, our favorite mascot. So why is it important that we think about this? They're not actually the same thing. I think the terms very commonly get used interchangeably, but they actually are two different mechanisms. Grit can help us achieve long-term goals and they increase opportunities, whereas resilience can help us deal with the stress and challenges of life. They're two actually different things that are interconnected with each other and they play off each other. So grit is perseverance and passion for long-term goals. It is goal-oriented, it is linked to performance, and that's where you really lean into that grit versus resilience, which is the process of adapting well in the face of adversity. How well do you pivot? That's something that family doctors do all the time. I tell my learners, my students, my residents, the job of a family doctor is to pivot. You don't know what's behind that door. You don't know what's coming at you. You may walk in and somebody's crying and you're saying, we're crying today. Okay, we're going to deal with this. That's what resilience is. In the face of adversity, trauma, tragedy, threats, or even significant sources of stress. This is a trait or a process or an outcome. And of course the question is, do you need both, right? Can we just get by with one? Do we have to have both of these things? The main difference is, again, this relationship to each other. They're both two positive personality traits that can help us be successful in life. And they help us bounce back from challenges and keep us going until we achieve our goals. So how do they increase resilience? We look, and there's lots of research on this. When I was preparing for this talk, there's hundreds and hundreds of scholarly articles that are out there on this. And when you think about how you actually incorporate both of these, we look at components of resilience, and these are 5 factors you want to think about in terms of how do I achieve my goals? How do I actually bounce back from this stress? You want to have a positive emotion that goes to that grit. What's my outlook on this, right? How engaged am I into working this problem? What kind of relationships do I have? That goes back to that concept of being socially isolated. The more socially isolated I am, the less likely I am to have those engagements. The more I perceive myself as being lonely, the less likely I have to have these strong relationships that help me be resilient and display grit. Are you getting meaning out of what you're doing this? Are you finding something that's purposeful and meaningful? I can't tell you how many of my patients in the last 6 months have said to me, Dr. V, I'm struggling with finding meaning. Dr. V, I used to volunteer here. I used to go to this activity. I went to the opera. I watched things on Broadway. I went to my kids' pickup hockey game. I was a soccer mom. I volunteered at the food pantry. I don't have those tools available to me to give me meaning and purpose. Having something that you find that brings you meaning and purpose absolutely plays into your ability to be resilient. And again, that sense of accomplishment. We are purpose-driven beings. We are purpose-driven individuals. You can see that from the time your child is little. When a kid learns how to tie their shoes by themselves, they say, I did it. I did it, Mom. I do all by myself. That sense of accomplishment and ownership you take of something and carry forward, that deliberate action. It's that self-fulfilling prophecy. It really ties into that happiness and well-being. It allows you to continue to master something. You can say, look at that. I made scones for the first time, right? When pandemic hit, we all made bread, right? I don't know about y'all, but everybody made bread. I learned how to make a different kind of scone. I'm a big baker. I accomplished this. I didn't think I could do that. I learned how to do this. We all done home improvement projects. That's why this is something you all have seen on social media and it's been talked about on the news. All our quarantine projects gave us a sense of meaning and accomplishment and allowed us to engage parts of our brain and engage with different resources we didn't think about before. We just didn't necessarily think of it as tools that have been studied by scientists and shown that they actually do help us move forward. So tools and strategies. I know for me, the analogy I use with my patients all the time at Sewell is we're going to put tools in your toolkit. And we have all inherently come with different tools. The tools that we have inherited are a product of our raising, they're a product of our environment. And you say to yourself, self, what is in this toolkit? We all didn't know that we needed a toolkit for a pandemic, right? Like, who knew that we were going to need a toolkit for dealing with a pandemic? However, the tools that you all are going to develop and that we're going to talk about don't just apply to dealing with a pandemic and the lessening of our social restrictions. These are tools I really want you to think about carrying forward into adulthood, carrying forward into different parts of your life. Because yes, it's great. They're going to help us deal with things. And God forbid we have another wave and have to go back into lockdown. Yes, it's nice to have these tools, but more importantly, these are going to be tools that you're going to use for yourself, for your family, for your children, and for those adults in your life, for those people in your life who fit that social isolation or loneliness category to be able to really move forward. So tools and strategies. I know for me, when I'm in the middle of doing something, when you're having that feeling, when you're in the middle of it, you don't necessarily realize that you're overwhelmed, that you're feeling stressed until somebody actually points it out to you. It kind of has to smack me in the face. So if you're not sure and you're saying to yourself, hey, I'm not feeling like myself, I don't think I'm doing so good, get assessed. There's lots of stuff you can Google. I generally tell my patients I'm restricting their internet privileges on a weekly basis because Google is usually my mortal enemy. I'm sure Dr. Kaiser-Smith and Dr. Brecher will agree. I'm usually like, no, don't Google. This is one of the things that you actually can Google. There's 2 links on here. And again, we'll make the slides available for everyone. The cdc.gov/BRFSS, it's a behavioral risk factor surveillance system. When you actually go to this page, it has all different categories, adults, children, teens, different categories for how am I actually doing with my mental health. You can take a self-assessment quiz. All you have to do is type it in, go to that link. What's nice is when you look at the CDC as a clearinghouse, it will also link you to more information that is reliable. That's the difference between going to the CDC and searching in that little search bar and going to Google. Google's going to take you anywhere. The CDC is going to take you someplace that has helpful information. The howrightnow.org, again, wonderful place for tips and tools that you can go to, really helping people when they're navigating what is helpful. Click on it, link to it. Again, these are validated, verified sources. You can also get assessed if you're really worried about how you're feeling mentally or emotionally, or how your family is feeling mentally or emotionally at your family doctor's office. Come see us at Sewell or any of our other rural medicine providers and locations. You can get an in-person assessment. If you're really feeling like, this isn't just isolation, this isn't just pandemic burnout, this is something larger. I'm not sleeping well. I'm having a hard time falling asleep or staying asleep. I'm so anxious, I can't shut this machine down in my mind. I just keep going from one thing to the next, to the next, to the next. You're going to come in and see your family doctor and say, Doc, I don't feel good. I'm having all kinds of heartburn. I've got irritable bowel. I'm running to the bathroom constantly. My appetite is terrible. I just want to stay on the couch with my blanket and not leave. And there's not a blizzard or an ice storm going on outside. I just don't want to engage. Or I'm super grumpy. I'm super irritable. Every little thing is setting me off. That's what we're here for. We want to assess you. We have tools. So when you come in to see your family doctor, even if you think you're getting a blood pressure check, we're probably going to check in with you and say to you, how are you doing? How are you feeling? What's going on? And we actually really mean it when we're asking the question. And if you say to us, Doc, I'm having all these symptoms, we may pull out one of these assessments as PHQ-9 or GAD-7. These are simple tools that we use. And by the way, our staff checks in with our patients too when they check them in. They're validated tools for looking for the presence of anxiety or depression, because we know that these disorders are on the rise. We know our mental health counterparts are really strained to the edges. We know personally from seeing my patients, the rates of anxiety and depression that I've been treating in my patients in the last year has just gone way up and plateaued. It has not gone down. So don't be surprised when we're assessing you if we're checking in with this. The other thing we may check in is with what's called an audit or a DAS score. Those are looking for alcohol use and substance use to make sure, hey, we all joke around about like it's pandemic life, it's airport rules, we're going to drink at 9 a.m. Actually, if you're doing that, it may be a problem. So don't be surprised if we're checking in with you about, do you find if you're a smoker that you're smoking more? Had you quit smoking and now you've gone back to it? I really do need that glass of wine every night, and the glass of wine is actually probably this big instead of this big. Gee, I've been at the liquor store a lot more lately. Don't be embarrassed to bring these up to us. Don't be surprised if we check in. This is just a way for us to check in with you so we know you're healthy as a whole person and not just that your blood pressure is under control. So next, whoops, sorry about that. So get educated. You want to know what your resources are. For kids, and this is something that parents, I know, I have a teenager. She's a freshman in high school. Her introduction to high school has 100% been online. Never thought my whole life this is something I'd be facing with my child. I see children in the office all the time. I can't tell you how many parents I've counseled and talked to. What am I doing with my kids? How do I help them? It's hard enough to be a teenager or a middle schooler nowadays. What do I do to help them? My grade school kids, how do they understand what's going on so that way they kind of are informed, but not scared? I remember watching Dr. Fauci release a statement before Christmas saying that Santa was safe and he would wear a mask, and he personally went to the North Pole and vaccinated Santa so he could bring presents to little kids. I cried. I still tear up and cry thinking about it, that somebody who was this educated took the time to say to a 5-year-old, this is safe. So for your kids, embrace their SEL needs or their social and emotional learning needs. Anybody who's in education will know what SEL means. These are really nice resources for children and families. The top one, the Edutopia, is actually run by the George Lucas Education Foundation and has wonderful resources for understanding what your children's emotional needs may be, what they may not be. Gives you some tips and tools for, well, how do we talk to a 7-year-old about social distancing? And when will they know if they can hug their grandparents or take that mask off? And why is it okay to hug grandpa, but maybe not the random person at the grocery store that usually bags your groceries? And how do they stay safe? It also helps you check in with your teens, because God knows it's hard to be a teen this age. Between social media, TikTok, what they're seeing online, you really want to anticipate what those needs are. As kids get older, their basis for their personality, their emotional needs get met by their peer group, not by us as parents. They're very isolated from them right now. How do we get them engaged in a way that's meaningful and safe? Take a look at these sites. They're validated, they're vetted, they're really good resources. Most importantly for your kids, fill up your tank. You know that old saying that your gas is not going to go many miles, if your car's not going to run if you don't have gas in your tank? It's so true. And people will say, well, doc, I don't have time to do this. I don't have time for self-care. I don't have time for me. The reality is you don't have time to not have time for 2 reasons. One, you can't be 100% of all things to all people, because then you leave nothing for yourself and you're no good to anyone. 2, you want to role model self-care to the people who live in the home around you. You're role modeling it to your 5-year-old. You're role modeling it to your teenager. You're role modeling it to your spouse and showing them, I value myself enough to take a time out. This is something we tell kids in our practice all the time, and parents. Timeouts ain't for kids. They're for grown-ups, because we're removing ourselves, we're de-escalating, we're engaging in self-care, we're filling our cup back up so we can come back into the situation, we can come back into the conflict and be emotionally present for those social and emotional learning needs. So again, check out the CDC. Believe it or not, we all think of the CDC as vaccines and information about COVID. Lots of resources for this. Don't be afraid to step into that and check it out. Again, get educated for adults. National Suicide Prevention Lifeline. Please keep this on your smartphone. Please keep it on your desktop. God forbid you need to reach out to somebody. Please reach out, get help. Know your resources. CDC.gov for mental health tools and resources. SAMHSA, always a great resource. It's the Substance Abuse and Mental Health Services Administration. We've had grants through SAMHSA. Really important. If you see somebody struggling, Gosh, I noticed my spouse is drinking a bottle of wine a night. Maybe I should do something about that. Gosh, I'm worried they used to do opioids in the past. I think they're hooked again. Where can I go to get checked in? Reach out to us, reach out to one of these hotlines. Super important that you've got these resources at your fingertips. So let's put these tools in your toolkit. We've got our toolkit analogy. We're ready to fill it up. We've been educated. We've worked through this. Here we go. Make a schedule. We are creatures of habit. We say that for a reason. We reproduce patterns of behavior that are familiar, not healthy. That's just how we roll. We like structure. For everybody who says they're a free spirit, we need some form of structure. Even if it's you're going to eat breakfast at the same time every day. You're going to meditate at the same time every day. I saw a patient Monday, first day of opening here at Sewell, super excited. She came in to see me. She has really struggled with the pandemic life. And when I finally got it out of her the last visit, I said, what is it that you need? And she said, well, I used to commute for 45 minutes and that was my me time. I said, what do you mean it was your me time? So I loved it. I had a long commute. Sometimes it took an hour. And that was my me time to listen to music or listen to a podcast or have a cup of coffee and decompress. And I looked at her and I said, you're getting your commute back. She looked at me like I was crazy. And I said, what time do you normally commute? I want you to set a timer in your home with your teenage child and your spouse and say, I'm on my commute right now. She was a different person. She had been drinking a bottle and a half of wine every night. She's down to 1 glass. Her blood pressure is the first time it's been under control in 6 months. This was 6 weeks ago. And she said, Doc, I got my commute back. So set a schedule. Give yourself time to take care of you. Be creative. Give yourself your commute back. Play a Zoom game with your family on the other side of the state, the other side of the country. Leverage technology. I know Zoom fatigue is very real. I call it the WebEx Olympics. There are days that I'm on the WebEx Olympics and I feel like I deserve a gold medal from it. And there are days that I don't even get anywhere near the podium. But leverage technology. I FaceTime with my best friend probably once a month. We pick a Friday night. If the weather's good, we're both sitting on our deck. We may or may not have a glass of wine or a bowl of ice cream, and we FaceTime. And we just talk. We make sure our phones are charged ahead of time. Leverage technology. And you'd be amazed at all the things that you really can do and experience. You know, the Academy of Natural Sciences usually once a month has a virtual tour. This is not going to go away. These virtual events, these virtual tours, these virtual interactions are not going to go away. They're here to stay. Get familiar with them, leverage it to your advantage. Take it outside. When it's not an ice storm, if you can go outside safely, go outside. Finally, we're going to talk about sitting with your feelings. You want to find your humor, and we're going to embrace your FFTs. So FFTs are ordering the chaos. One of my quarantine projects, because I've had a couple, was to start listening to podcasts. And when we started listening to podcasts, I'd walk my dog. My dog thinks quarantine is great. She thinks it's wonderful. And we listened to Brene Brown's podcast. She's a research psychologist. She's a godmother for vulnerability and shame. And FFTs are effing first times. And that's what I want to leave you guys with. Tools. Normalize it, put it in perspective, reality check your expectations, build in rest and recovery, and get and stay FFT fit. Think about these tools, take a look at that link. It's not going to be like this forever. I'm doing the best I can. Am I being fair to myself? Rest, recover, and stay well physically. That's all I have for you folks. Please come visit us at Rowan-Virtua. Oh, I thought we had a picture and I guess I don't. Please come visit us at Rowan-Virtua. We are happy to be here. We're excited to see you. We are on Tanyard Road, right on the College of Rowan College of Gloucester County. So it was a pleasure to talk to y'all. Thank you, Dr. Kaiser-Smith.
Dr. Brecher, you're on.
Today we're going to review osteoporosis, and it's so important that everybody know their risk factors. So hold on to your seat. Here we go. Bone is living tissue. People think of their skeleton as being just static, but it's really not, because there's a constant process of what we call remodeling. We move furniture, we lift things that are too heavy, and there's micro damage every time we do something. So the bone has the ability to repair. even though we're not going to grow much bone, we can repair these small little, they're not fractures, but little soft areas. So we have to realize remodeling is a process. I liken it to the potholes in the streets of Philadelphia. So the crew comes in and they actually have to dig out the bad bone. And the next day the crew comes and they actually fill in the bone that was damaged. So remodeling occurs throughout our lifetime. So in children and teenagers, there is more building than there is remodeling. There's more osteoblasts that build bone and less osteoclasts that eat bone. But once we achieve our peak bone mass, which occurs in the early 30s, we do not ever have more building. We actually just have repair. What happens at menopause is that we have more hole diggers than hole fillers. Therefore, that's what osteoporosis is, when we start to lose bone density or the quality of the bone. Now, this is just a great picture, electromicrograph of healthy bone. So this is what we call trabecular bone. This occurs in the vertebrae of your spine. It occurs in your hips, and at the end of your long bones, you have this type of bone, which is called trabecular. So on the left is healthy bone, and that's as good as it gets. As that becomes weaker, it becomes disconnected. An osteoporotic bone, osteoporotic, there's more pores, there's less connectivity, there's less structure, and there's more fragility. So our peak bone density is determined by certain factors. One is how healthy are you in your teen years and in your early 20s and your late 20s, because if you do all the right things, you will achieve your best peak bone density. And some of that has to do with nutrition. People with eating disorders never achieve their peak bone density. People with menstrual disorders have difficulty achieving peak bone density. Those that are sedentary. So things that are good for bone are good nutrition, physical activity, and then there's certain medications that I'm going to review that increase your risk for bone loss. So what's the definition? And I kind of said that already. Osteoporosis is characterized by weakness. Believe it or not, osteoporosis doesn't cause pain. So even though it's weak, you may never know it's weak. Unless we do a bone biopsy and look at it under the microscope, we don't know it's weak until it breaks. So we know that bone loss is a natural process of aging, because what happens is bone is built until your mid-30s. You're probably pretty stable until menopause. Bone loves estrogen. So bone has receptors for estrogen that allow bone to stay strong. But once women lose their estrogen, that's when they start to lose the density of their bones. So it is somewhat a natural process. But if we think back to the Middle Ages, we didn't live much past 30 because we'd be eaten by a dinosaur. So now that we've achieved the ability to live a long, healthy life, are we okay having weak bone and having fractures? That's really not a good part of aging. So we do feel that intervention is very important so we don't have broken bones. 9 million Americans over the age of 50 have osteoporosis, and I would tell you most of them don't know it. 1/2 of all women and 2 out of 5 men will develop osteoporosis during their lifetime. Remember, no symptoms. It does not cause pain, it just causes broken bones. So there are 2 million fractures occurring every year related to osteoporosis in the United States. And we always say that at the National Osteoporosis Foundation, their big tagline is 2 million too many. So osteopenia, I love when patients come in and say, oh, it's only osteopenia. Well, osteopenia is low bone density. That means that you've lost bone from your peak bone density. It can be a risk factor for fracture. Some people will fracture when it's just osteopenia, but not all. So this is an opportunity to assess your risk factors. There are some risk factors for bone loss that we can change, and there's some that we can't change, and I'm going to go over those. So who gets osteoporosis? Well, in the US, 53 million people either have osteoporosis or osteopenia and at high risk for fracture. It affects women and men of all races and ethnic groups. We know that women are affected earlier because women lose estrogen around 45 to 55. So that loss of estrogen puts women at much higher risk. Men tend to lose bone later, more like in their 70s, unless they have other risk factors. So let's talk about what we can change and what we can't. Things we can change is being female. And that's kind of why we're here. It has to do with the whole estrogen thing. Estrogen is very good for us. It decreases our risk for heart disease, but loss of estrogen increases our risk for heart disease and bone loss. So once you're past menopause, or even people who have lost menstrual periods when they're young, they're at very high risk because it's the cycling of estrogen that keeps our bones strong and our heart. So if you have family members, especially if you have a first-degree relative who broke their hip, your risk is very, very high. And I always say we can change who we come from. So thin, small, or petite body frame. And that really means, that cutoff is about 128 pounds. So anybody who weighed 128 pounds or less at the age of like 50 probably is at highest risk, because we realize that your skeleton probably is not very dense or very big, so that when you lose bone density, you did not have extra. Aging, aging is a privilege, so that's not something we want to change. And then any inflammatory condition, regardless of whether it's bone related or not, anything that causes chronic inflammation in your body increases your risk for bone loss, because it activates the osteoclasts, which are the hole diggers. So some of the treatments are bad too, but specifically inflammatory disease is bad for your bones. So some of them: rheumatoid arthritis, celiac disease, thyroid disease, inflammatory bowel disease, and that category of COPD/asthma. If they're actively inflamed, it increases your risk for bone loss. So anybody who's had a broken bone after the age of 50 that was without trauma, that means if you fall from standing height and you break something, that's thought to be osteoporosis. Now, if you're on rollerblades, if you fall down the steps, if you're in a car accident, that would be a traumatic fracture. But, I'm in an age group where my friends now go to roller skating parties for their grandchildren, and they get on roller skates for the first time in 20 years, and they have a wrist fracture. That's osteoporosis. Use of certain medications. We know that steroids are very, very difficult on the bones. So it's something we need to be aware of. People that are on steroids are on it to save their life because they have serious conditions, but we have to recognize that they are a risk factor for the bones, so we have to treat appropriately to monitor the bones. Anti-convulsants, which are medications used for seizures, some of them have very high risk for bone loss. Again, these are things people need to be on, but we have to take precautions and evaluate bone health. Proton pump inhibitors. These are drugs like the purple pill, omeprazole, Prilosec, Nexium, Acifex. All these medications interfere not only with bone development, but also with calcium absorption. So I, once again, don't tell people to stop these drugs, but assess if they need to be on these medicines for a very good reason, then we have to work on how to keep their bones strong with other ways. So I don't ever discontinue medications. Instead, I just accept that these are part of this person's risk factor, and then we modify. We make other modifications to make the bones maybe either lose less or stay stronger. And a history of falls. So fractures are two problems. One is low bone density and the other is hitting the ground. So, what causes falls? Poor vision, poor balance, arthritis in weight-bearing joints, seizures. We have to think about fall risk. Sometimes it's things in the home, poor lighting, throw rugs, extension cords, little pets that get underfoot. So we have to compromise and think about how we're going to decrease fall risk and how we're going to maintain or improve bone strength. Factors we can change: inadequate calcium intake. Every single time we use a muscle, it uses calcium. So we know that our heart is our most important muscle, and our heart is going to pump whether we eat calcium or not. So where's the calcium coming from? It's coming from the bank, and the bank happens to be your skeleton. So every day when you're getting inadequate nutrients, calcium particularly is going to come out of your bones, because most of the mineral in bones is calcium. So it's a great source. So don't allow that, because these are constant withdrawals out of your skeleton. And while they're small, over a lifetime, 5, 10, 20 years, it's a lot of loss. Vitamin D is absolutely important in order for your gut to absorb the calcium. So getting calcium without vitamin D is not going to help. Exercise. Exercise is a lot of things. Exercise is a walk. Exercise is doing housework. Exercise is walking up and down the steps. Anytime that you are opposing gravity, meaning you're standing, you're walking, you're marching, you're dancing, that is what we call exercise for the bone. The bone tends to be stimulated when it works against gravity, which is why they do bone health studies and osteoporosis studies on astronauts. When you take astronauts and put them up in space and they lose gravity, they come back and they lost bone density. So we know that standing up against gravity is good for your bones. We also know people that are sedentary, and even looking at people that are in bed all night, there is negative impact on bone from being in one place and not opposing gravity. Smoking, bad for the bones. Alcohol, bad for falls. So 3 or more drinks of alcohol a day increases your fall risk. And then excessive intake of caffeinated beverages. And I'm also going to add soda, because the phosphates in the carbonated sodas tend to bind the calcium in the bones. So we like to think about that in moderation. Fractures, that is equivalent to broken bones. So there's over 2 million. Remember, don't ever forget, 2 million too many fractures a year in the United States. And they are low trauma fractures, fall from standing height. Sometimes when the bone is very weak, especially in the spine, I've had people that say they just rolled over to pull the covers over their body and they end up fracturing a vertebrae. And if you look at the top right corner, what you see there is vertebrae. You see the spine. Now what happens is a vertebral compression fracture is when the vertebrae goes from being 1.5 inches tall to 1 inch tall. Now, what happens is it tends to compress in the front more than the back, because the back is a little more stable with all the spinous processes. So when you have a couple of these, what we call wedge fractures, this is when you start to see dramatic posture changes where people tends to be bent forward and they can't straighten up, because if you put 2 or 3 of these together, you're going to end up with a pretty severe forward curve. And that's going to affect everything about you. Not only your posture, it's going to affect your ability to take a deep breath. It's going to affect your digestion. It's going to affect the way your clothing fit. People lose their waist. They end up with their belly pushing out further because you've got a lot of bow in there and has nowhere to go, because now you've lost the distance between your hips and your waist. So these fractures can be deforming, painful. They can interfere with a lot of your other bodily processes. The most common fracture in the early menopausal woman is a wrist fracture. And that's because we have still those balance things that we're able to get our hands out to protect our face. So when you fall on an outstretched arm, the highest risk is that you're going to fracture your wrist. So what happens after 65, we see very few wrist fractures. And it's not because the wrist gets stronger. It's that over 65, people sometimes don't have that reflex to get their hand out, and instead they break their hip. So at 65, hip fractures go up, wrist fractures go down. What the problem is, many people break their wrist and nobody tells them, go check for osteoporosis. This could be serious. So keep that in mind. I walk down the boardwalk in the summer and I see women my age with casts on their arm, and I want to approach them and say, did you have your bone density checked? You know, unsolicited advice, not very good. Vertebral fractures, as I said, pain, posture. Hip fractures, most hip fractures require hospitalization, they require surgery, they require rehab, increased risk for pneumonia, increased risk for blood clots, and because of that, there's a 20% increased risk of dying within a year after the hip fracture. I would say a lot of that really has to do with your general health going in. I see many people go in, come out, they do great, but if you already have health problems, this is a huge risk factor. How do we evaluate for osteoporosis? It's called a DEXA, and it uses an X-ray source, but it's about 1/5 of the radiation of a chest X-ray. Very, very simple thing to do. And everybody should have a baseline DEXA once they're 65 or earlier if they have other risk factors. But, you know, if you come to my office where we do full evaluations for bone health, it's a history and it's a physical. We get a lot of history. We go over your medications. We assess your risk for falling. We talk about exercise, fall prevention, and some people will benefit from medication. Some people don't need medication, but it's important to know because this is proactive. We don't want to wait until there's a fracture. So Follow-up appointments occur because we want to make sure. It's like, if we look at the old days, people would get prescriptions for estrogen, they walk out the door and they never take it. It's important if we decide on medication that you buy in, or if you don't want medication, then we discuss that too. But it's important to know your bone health. A DEXA is super easy. As you notice, you don't even have to take your clothes on. You're not enclosed. It takes less than 15 minutes, very low radiation. It gives us a lot of information. And what it does is it compares the density in your bones. It checks your spine and your hip, but it compares your density with that of somebody who's your height, your weight, your size, and your race at 30. So it tells us how much you might have lost since your peak bone density, and that gives us an idea of your fracture risk. How do we manage risk factors? Well, adequate calcium and D, and I have to say the most effective way to get nutrients is through food. Big on dietary sources. So, you know, we use supplements if we have to, but they're not as well absorbed. So trying to get calcium through your food is very, very important. The adequate amount of calcium for an adult female is somewhere between 1,000 milligrams and 1,200 milligrams. But a lot of that depends on your own personal health. You know, there's some people that shouldn't be on calcium supplements because they have kidney stones. There's other people that have kidney disease and they might need more calcium. So it's very individualized, and I'm giving some basic ideas, but they're really not for everybody. Many people require vitamin D. D is something that we get from the sun when we're young, but we don't absorb it as well as we're older. And now we're wearing sunscreen, so we hardly absorb it at all. So we always check a vitamin D level and discuss supplementation if needed. Exercise. I say weight bearing was good for your bones, but strength exercises are very good for your balance. So remember, fractures is a combination of low bone density and the risk for falling. If we stay stronger, if we have core strength, if we have arm and leg strength, we're going to decrease our risk for falling. We work on postural exercises. People with osteoporosis should not be doing exercises that cause them to flex their spine. Remember, I showed you the wedge fractures. If we do too much flexion, it increases the weakness in the front of the vertebrae if your bone density is very low. So if any of you do yoga, if you have osteoporosis, we really do not recommend the cat pose because you're flexing your spine. Balance is important, and I did mention fall prevention. Medications, not a lot of time to go into all of them, but I'm going to tell you there's two basic categories. There's anti-resorptives, and if I simplify it, these are the medicines that decrease the amount of hole diggers. It doesn't stop them entirely, but it slows them down. So maybe we can have better balance and more bone growth, and it definitely decreased risk for fracture. So studies are very conclusive that it lowers fracture risk. Estrogen itself is an anti-resorptive, but it's come off the list as treatments because of all the other potential risks for estrogen replacement. But there's a bunch of classes of medications that all work as anti-resorptives. So that's one way to treat people medically. The other is what we call anabolics, and these are medicines that increase the whole fillers. They're anabolic, they build bone, and they build healthy bone, and that's how they got approved. So each person, treatment is very individual. It's either an anti-resorptive or an anabolic. So some horrible statistics. After an osteoporotic fracture, only 20% of people are on treatment, which means we're really missing 80% of the people that are going to go on and have another fracture if we don't do something. Half of the people who break a hip have had a prior fracture that was not treated medically. Nothing was done to prevent further fractures. So fractures beget fractures. And out of 1,000 women, 500 will suffer a fracture without treatment for osteoporosis. So statistics are high. Who should seek evaluation? So if you've had a low trauma fracture, a fracture after a fall from standing height after the age of 50, you should be evaluated. If you've had a premature menopause before the age of 45, anybody over 65 should have a bone density test just so they know where they are. And then if you have other high-risk conditions, you should be tested or evaluated around the age of 50. And that's rheumatoid arthritis, celiac disease, inflammatory bowel disease. Or if you're on high-risk medications, you should be evaluated with a DEXA. simple study. So our goal is fracture prevention. We want to stay active, healthy, and engaged. And we say, yes, bone loss is associated with aging. Fracture is not a natural process. It causes a lot of disability. Following a healthy lifestyle is important. And again, 2 million too many. And that is a pyramid of casts that people wore because of fractures. So I think, yes, I'm finished. I think we're a little tight on time. We can take some questions if you want to put them into the chat section. Any questions that don't get answered, we can have them emailed to us if maybe Jane can do that, and we could answer them at that point. I just want you to know that we're all faculty here at Rowan School of Osteopathic Medicine. We are all available for patient consultations. My office right now is in Stratford. Dr. Vermeulen is in Sewell. And certainly we're happy to entertain any questions you might have.
Dr. Brecher, we have a question. What's the difference between osteoarthritis and osteoporosis? Is it not the same thing?
Actually, osteoarthritis is a process that occurs at the joint when there's a loss of cartilage, and that usually does result in pain and deformity, and it can also occur in the spine. Whereas, as I showed you, osteoporosis is a structural problem inside the bone, which is painless. So therefore, there is no pain until you break something. I just saw a question about calcium. Calcium supplements. Okay, so let's talk about it. The best calcium is going to be from food. So I know that there's a lot of people, especially in adult years, that don't tolerate lactose, they don't tolerate dairy products. So we look at some of the greens may have calcium, almonds have calcium, sardines have calcium, salmon from a can has calcium, but really the best products are dairy products. 8 ounces of milk, you can use lactate, you can use soy milk, they're all supplemented with calcium. So 8 ounces of a milk product is about 300 milligrams of calcium. For those people who use supplements, just be aware the most common supplement on the market is called calcium carbonate, because calcium is a salt, so there's always 2 words. Calcium carbonate is the least expensive, but there's 2 problems. One, it can cause bloating, constipation, and gas. And the other, it needs acid to be absorbed. So if you're on an acid blocker for heartburn or reflux, you cannot take calcium carbonate. It will not be absorbed. So therefore, you switch to calcium citrate. So calcium citrate is another form of calcium that's available on the market that does not cause gas or bloating. It's more readily absorbed, and it doesn't require acid. So that's what I recommend, is that if you have to be on an antacid, you consider calcium citrate. I like to ask people to get at least half of their calcium products from food, if you can. So if you get 500 from food and use a supplement for the other 500. The other thing I find super important is that you understand that getting extra calcium is not going to find its way to your bone. Once you've achieved your 30-year-old peak bone density, calcium only comes out. So if you get extra calcium, it's only going to end up in your kidneys. It's not going to be helpful. So while enough is important, too much is really, really not good. So I just can't stress that enough. You know, the goal is about 1,000 to 1,200 milligrams a day if you have normal kidneys. But I know I've had people that have been super motivated and they get too much, and that could be another problem. Is seltzer the same as soda? And that was another question. And I would tell you, no, you can have seltzer. I don't think there's phosphates in seltzer.
Dr. Vermeulen, we have a question for you. All these tools in the toolbox, when COVID's over, how am I going to still get myself to keep doing this?
Great question. You know, starting a habit takes a while, and it's one of those things where it's the old Allen Iverson quote, you talk about practice, right? This is practice. Continue to use your schedule. Use your smartphone to its advantage. I think that's probably the one tool I recommend to patients the most. If you like a handwritten calendar, write it down. Also, give yourself permission to roll into things. Don't try to make all these tool changes at once. Start and say, okay, this week I'm going to commit to myself that I'm going to walk 20 minutes twice a week. Here's my date and time, and this is what we're doing. Next week, we're going to go up to 30 minutes, 3 days a week, gradually roll it out. And eventually, when you're in these habits, they're going to be just that. They're going to be habits, and you're going to notice when you're not doing it. So use your smartphone, write it down, and make an appointment with yourself. We tend to keep appointments. We don't tend to keep to-do lists. So if you use your appointments, they're really going to use to your advantage. Great question.
Well, we're coming up on the end of our hour, which went so quickly and was so full of such great information. I wanted to thank you all for your attention and your interest in our program. We are asking for topics. If you have a topic that you would like to see addressed, we will be meeting monthly through June, taking the summer off. We'll come back again in September. We have plans to address topics that are for youth, pediatric topics, as well as the elderly. And we're going to continue to focus on the perspective from women. We think it's really, really important that we take care of the caregivers. So thanks again. Send us your topics, and we will see you in April.